Just a minute. Okay. Sorry about that. Into chapter 21, which has to do with alterations in hematologic function. The chapter starts off with anemia. Anemia is a decrease in circulating red blood cells or a decrease in the quality or quantity of hemoglobin. Anemias are classified by one in two ways, either by their cell size, which the suffix will end in cytic, or by their hemoglobin content, in which their suffix will end in chromic. Anisocytosis is red blood cells being present within the body in various sizes, and poikilocytosis is red cells are present in various shapes. Anemia can affect all organs and tissues, and of course when that happens, there's a decreased oxygenation to organs and tissues. And some of the most common symptoms of anemia are feeling fatigued, having shortness of breath or dyspnea, feeling overall weak, syncope, such as if you don't get enough oxygen carrying red blood cells to the brain, angina, which of course would affect the cardiac muscle and tissues. Tachycardia is a compensatory response to anemia in order to try to circulate what is available faster. And if all else fails, organ dysfunction. And if that's not corrected in a timely manner, then it can also lead to complete organ failure. Macrocytic-Normochromic anemias are those that have large red blood cells with normal hemoglobin. This disorder may also be termed megaloblastic. Basically how this happens is that unusually large stem cells in the bone marrow will mature into very large erythrocytes. And it happens because a disruption occurs in the DNA synthesis, leading to immature nuclear development. The most common type of macrocytic-normochromic anemia is pernicious anemia, which is a deficiency in B12, either because there's an absorption problem or some other problem. Pernicious anemia is fatal if the B12 is not replaced, and it requires a lifelong replacement process for the B12. And symptoms of pernicious anemia are fatigue, weakness, paresthesias, difficulty walking, anorexia, abdominal pain, weight loss, and sore tongue. In the most severe cases of pernicious anemia, an altered mental status can occur, confusion being the highlight. As I said, the treatment is by replacing the B12 either parenterally through subcutaneous, either parenterally through injection or high oral doses of vitamin B12. Again, it's lifelong treatment. Folate deficiency anemia is another type of Macrocytic-Normochromic anemia, and just like you would guess, it is a deficiency in folic acid within the body. Usually, there's a problem with the absorption of folic acid from the small intestine. Very similar presenting symptoms as pernicious anemia, except rarely does it have any neurological manifestations. And just like with pernicious anemia, folate deficiency anemia requires lifelong replacement by daily oral therapy of folic acid. Microcytic-Hypochromic anemias are where there's small red blood cells with low hemoglobin. The most common among these is iron deficiency anemia. It is slow to develop. The iron deficiency may occur because of a nutritional deficit or from blood loss. The symptoms are fatigue, weakness, dyspnea, alteration of various epithelial tissues, and vague neuromuscular complaints. The alterations in epithelial tissues that you might see are brittle, thin nail alterations. The nail may appear to be spoon-shaped. A very red tongue with soreness or pain. And then at the corners of the mouth, sores and dryness, which is called angular stomatis. And then the last type of microcytic hypochromic anemia is sideroblastic anemias. What causes these type of anemias to happen is that the mitochondria of the erythroblasts have too much iron, causing them to develop an extra side. There are various causes for these, but they all share in one alternation, and that is in the heme synthesis. And then there's the Normocytic-Normochromic anemias. These are all which have red blood cells that are normal in size and have normal hemoglobin concentration. But what happens is that there's an insufficient number of these circulating in the blood. The types are aplastic, post-hemorrhagic, acquired hemolytic, hereditary hemolytic, and anemia of chronic inflammation. Aplastic anemia is when the red blood cell production is depressed within the stem cells. Post-hemorrhagic occurs with blood loss. While the red blood cell production increases, there's just not sufficient iron attached to them. The iron cannot generate fast enough to keep up with the red blood cell production in post-hemorrhagic anemia. Acquired hemolytic anemia is where red blood cells are fragile and are prematurely destroyed. Hereditary hemolytic is one that we're all familiar with, sickle cell anemia, and that's a hemoglobin synthesis issue. The cells are lysed and phagocytized earlier than usual, resulting in a high rate of red blood cell damage. And the last one, chronic inflammation, occurs when, in the presence of chronic infection or malignancy, there's a need for more red blood cells than normal. And then there's the myeloproliferative red blood cell disorders, all falling within the category of polycythemia, which is an overproduction of red blood cells. It's a disorder of the stem cell of the bone marrow. Both hyperplastic and neoplastic bone marrow alterations occur in order for polycythemia to exist. There are two forms of polycythemia, relative and absolute. In relative polycythemia, the results are usually from dehydration. It's usually a minor, self-limiting condition, and it can result from diarrhea, excessive emesis, inadequate water intake, or use of diuretics. And the treatment is simply fluid replacement for relative polycythemia. Absolute polycythemia has two categories, primary and secondary. Secondary is the most common. Primary absolute polycythemia is a genetic mutation resulting in an increase of the erythropoietin hormone. This is also known as polycythemia vera. Secondary polycythemia is a physiologic response caused by increased erythropoietin hormone secretion due to hypoxia. And that can occur when individuals are in elevations above 10,000 feet, in people who smoke, or people who have COPD or heart failure. Yep, all those. Alterations of leukocyte function, and this, of course, is disorders of the white blood cells. Quantitative alterations of leukocytes, whether it be too many or too few, all occur within the bone marrow. There's a dysfunction within the bone marrow which leads to premature destruction of cells in the circulation. And quantitative changes in leukocytes occur in response to invasion by microorganisms. And this is where the slides don't quite match the book, because there are several disorders which the book mentioned in the key terms. So I'm going to go over them, and when I have a slide that matches the notes, I will go to it. But leukocytosis is a leukocyte count which is higher than normal, and it can be caused by physiologic stressors and invasion of microorganisms. Leukopenia is where the leukocyte count is lower than normal. It's usually caused by pathologic conditions such as malignancies and hematologic disorders. Granulocytosis or neutrophilia is where there's an increase in neutrophils, eosinophils, or basophils, and it occurs in response to infection and inflammation. It can be detected very easily by laboratory testing using the white blood cell differential. And when you see it in the differential, it's termed a shift to the left. And when and if it returns to normal, it's termed shift to the right. So neutrophilia would be an increase in the neutrophils, and neutropenia would be a decrease in the neutrophils. Neutropenia occurs with prolonged severe infection or decreased production of neutrophils. It usually results in reduced survival time. Eosinophilia is where you have an increase in eosinophils. This happens in response to allergic disorders, parasitic invasion, and ingestion or inhalation of toxic foreign substances. While eosinopenia is a decrease in eosinophils, usually occurs in response to inflammation and can occur in response to surgery, shock, trauma, burns, or mental distress. Basophilia is an increase in the number of basophils. It's a rare disorder, and it too is a response to inflammation or an immediate hypersensitivity reaction. Basopenia is a decrease in circulating number of basophils. It occurs with infections, hyperthyroidism, and long-term steroid therapy. Monocytosis is an increased number of circulating monocytes. It's usually transient. It occurs during the late or recuperative phase of an infection. And monocytopenia is a decrease in circulating monocytes, but there's very little known about what causes this condition. Lymphocytopenia is a decrease in the number of circulating lymphocytes. It's usually associated with neoplasms, immune deficiencies, or certain drugs, viruses, and radiation can cause destruction of the leukocytes, of the lymphocytes. And then lymphocytosis is the opposite. It's an increase in the number of lymphocytes in the blood. It occurs usually in acute viral infections such as Epstein-Barr virus. Infectious mononucleosis, or IM, is an acute infection of the B lymphocytes. It is most commonly caused by the Epstein-Barr virus. Actually, about 85% of those cases result as an Epstein-Barr virus. And the Epstein-Barr virus is transmitted via saliva from close personal contact, such as kissing. Classic symptoms of infectious mononucleosis is fever, pharyngitis, swollen lymph nodes, especially around the cervix area, and fever. If severe enough, it can cause splenic rupture and cause death, and also the proliferation of infected B cells may be uncontrolled, and if so, it can lead to B-cell lymphoma. The treatment usually consists of rest and symptomatic treatment. Leukemia is an uncontrolled proliferation of leukocytes. What happens is that the leukocytes overcrowd the bone marrow, which results in a decreased production and function of the other blood cells. The classification of leukemia is dependent upon two things: the cell type involved, whether it be myeloid or lymphoid, and the rate of progression, whether it be acute or chronic. Acute leukemias are often abrupt and chaotic, where one is feeling well one day and is very sick the next. And chronic leukemias have a slow and insidious presentation. There are four major types of leukemia. Within the acute category, there's acute lymphocytic leukemia, or ALL, and acute myelogenous leukemia, or AML. The acute lymphocytic leukemia usually occurs in children, and it's when you have too many lymphoblasts. The acute myelogenous leukemia is the most common leukemia that you see in adults, and it has too many myeloblasts. Some of the manifesting symptoms that you will see is depression, bone marrow depression, signs and symptoms, fever, anorexia, and sometimes neurologic symptoms. We don't know what the exact cause is of some of these leukemias, but they all result in clonal disorders driven by genetically abnormal stem-like cancer cells from the bone marrow. In chronic leukemias, you've got two types: chronic lymphocytic leukemia, or CLL, and chronic myelogenous leukemia, or CML. Again, as I mentioned, chronic leukemias have a slow, insidious presentation. They all result usually in swollen lymph nodes, and how these occur is that there are a volume of abnormal immature white blood cells called blasts fill the bone marrow, and then they spill into the blood. And also the blasts that are in the marrow crowd out the production of other blood cells. Symptoms that you may see with chronic leukemias are fatigue as a result of anemia from red blood cell production inhibition, bleeding caused by thrombocytopenia because the platelets have also been crowded out of the bone marrow, and then fever secondary to infection, and then anorexia and weight loss. The treatment varies depending on the type of leukemia you have. Sometimes it's just observation, sometimes it's steroids, chemotherapy, monoclonal antibodies, and then transplant options. Moving to alterations of lymphoid function. Lymphadenopathy is simply enlarged lymph nodes. Usually these are palpable, and sometimes they may be tender. Malignant lymphomas are neoplasms that develop from proliferation of malignant lymphocytes into the lymphoid system. They can be caused either by genetic mutations or viral infection. Transformation causes uncontrolled and excessive growth of cells in the lymph nodes to produce tumor masses. The World Health Organization classifies these based on both their structure and cell lineage. The four major categories of lymphomas are B-cell neoplasms, T-cell or natural killer cell neoplasms, and then the two which you are probably most familiar with, Hodgkin and non-Hodgkin lymphoma. Hodgkin lymphoma is an abnormal genetic transformation of the Reed-Sternberg cell. It can be complicated or can occur after an individual has experienced the Epstein-Barr virus. Its most dominant presenting characteristic is a painless mass in the neck, and a person can remain asymptomatic or undetected with Hodgkin lymphoma for years. So it's important that in the health history that you ask about infectious mononucleosis, because that is a precursor in a lot of the Hodgkin lymphoma cases. The treatment includes chemotherapy, radiation therapy, and surgery. And just like whenever chemotherapy or radiation therapy is given for other conditions, secondary cancers, cardiovascular disease, and an entire array of other health problems can occur and drag on for months or years after treatment. Non-Hodgkin lymphomas are heterogeneous groups of proliferative lymphoid tissue neoplasms. So it's a bunch of tissue that has very diverse characteristics coming together to form one tumor. Some of these are caused by clonal expansion of B cells. Some are caused because there's an active A chromosomal translocation. that deletes tumor suppressor genes. And some are caused by viruses. Over all that. In non-Hodgkin lymphomas, most of the time the lymph nodes are painless, and they enlarge and transform over a period of months or years. Treatment includes radiation therapy, chemotherapy, target therapy through protease inhibitor therapy or monoclonal antibody therapy, plasmapheresis, biologic therapy, and just watchful waiting. Burkitt lymphoma is a B-cell tumor and involves the jaw and facial bones and sometimes the abdomen. It is the most common type of non-Hodgkin lymphoma in children. It is common in Africa, and usually results as a latent effect of a previous Epstein-Barr virus infection. Treatment is by intensive chemotherapy. Multiple myeloma is a neoplasm of plasma cells that occurs within the bone marrow. Usually, multiple myeloma is not found in blood. Multiple malignant tumor masses of plasma cells are scattered throughout the skeletal system, and it's sometimes found in soft tissue. Usually results in hypercalcemia, renal failure, and bone lesions. Most of these are genetic. Well, some of these are genetically linked by chromosomal translocations, but the exact cause of multiple myeloma is not known. Risk factors for multiple myeloma include previous radiation therapy, certain chemicals that you've been exposed to, and a history of monoclonal gammopathy of undetermined significance. Treatment includes chemotherapy, radiation therapy, plasmapheresis, and stem cell transplant. Splenomegaly is the enlargement of the spleen. In some individuals, an enlarged spleen may be considered normal, but usually the presence is associated with various diseases. Causes of splenomegaly is acute inflammatory or infectious processes, digestive disorders, infiltrative processes, tumors or cysts, and hypersplenism is overactivity of the spleen. It does not exist on its own. It's a phenomenon that occurs because of the enlarged spleen. And when hypersplenism occurs, it results in sequestering within the spleen of blood cells. That causes an increased destruction of red blood cells, an increased destruction of white blood cells, and increased destruction of platelets. Thrombocytopenia is characterized by a platelet count below 150,000 and less than 50,000 increases the potential for hemorrhage. There are primary and secondary forms of thrombocytopenia. They're usually associated with autoimmune diseases, viral infections, drugs, nutritional deficiencies, chronic renal failure, cancer, radiation therapy, bone marrow hypoplasia, and DIC. And mentioned on the slide also heparin-induced thrombocytopenia, which the textbook did not go into. Thrombocythemia is where you have an increase in platelet counts, usually higher than 400,000. If it ever exceeds an count of 1 million, then you become symptomatic. And counts above 1 million increases the risk for intravascular clotting or thrombosis. Myeloproliferative neoplasm that results in thrombocythemia is characterized by an increase in platelet production within the bone marrow. This can also cause an increased production of red blood cells. Qualitative alterations in platelet formation prevent that platelet plug formation from occurring in step 2 of homeostasis that we talked about in the last chapter, and can result in prolonged bleeding times. Disorders affecting platelet function can either be acquired or congenital, but acquired disorders are more common than congenital. There are several disorders of coagulation. And again, coagulation can be affected by either too many or too few platelet cells. And just revisiting chapter 20 for just a moment, coagulation is always stimulated by the presence of tissue factor that is released when a vessel is damaged or injured. Coagulation is impaired when there is a deficiency of vitamin K, so vitamin K must be present. Sufficient quantities of vitamin K must be present within the body for coagulation to occur. A deficiency in vitamin K leads to insufficient production of prothrombin, and also leads to an inefficient synthesis of clotting factors 7, 9, and 10. Vitamin K deficiencies are also associated with liver diseases. The most common type of coagulation disorder is disseminated intravascular coagulation, or DIC. It is an acquired clinical syndrome. What happens with DIC is that widespread activation of coagulation occurs throughout the body. Fibrin clots form in medium and small vessels throughout the body. And those fibrin clots lead to blockage of blood flow to organs, which can lead to organ failure. And if it becomes severe enough that the clotting becomes of a magnitude that's severe enough, then there will be a tendency for the individual to bleed despite widespread clots. Because what happens is that the platelets and the clotting factors that do respond begin to be lysed and ineffective. DIC can be secondary to a wide variety of clinical conditions, but the most common one is sepsis. I already went over that. I went over that. There are several laboratory tests that can be used to detect DIC. And what you would see in laboratory tests is that they confirm thrombocytopenia. One of the classic things you will see in laboratory testing is a rapidly decreasing platelet count, especially on repeated testing. There will be prolonged clotting times. There will be presence of fibrin split products. And then there will be a decreased serum level of coagulation inhibitors. The treatment for DIC is aimed at three goals, one being to eliminate the underlying pathologic condition contributing to it, controlling the ongoing thrombosis that's occurring widespread throughout the body, and trying to maintain organ function. Thromboembolic disease is where either you have a fixed thrombus, fixed blood clot, or you have a moving embolus, a moving blood clot throughout the body. But regardless of whether it's moving or fixed, it usually blocks the flow of a vessel. It denies nutrients to tissues distal to the occlusion. And if the clots get to the heart, brain, or lungs and cause an obstructive blood flow, death usually results. Thrombophilias can be hereditary or pathological. With hypercoagulability, usually there are deficiencies in proteins S and C and AT3. Studies. There's one thing on here which I can't find. Let me see what it is here. Right there. The Virchow triad refers to three factors that can cause thrombus formation either in the arteries or the vein. The first one being a loss of integrity of the vessel wall, abnormalities of blood flow, and alterations in the blood constituents. So Virchow triad refers to both arterial or venous thrombi caused by loss of integrity to the vessel wall, abnormalities of blood flow, or alterations in blood constituents. And that's all I have on chapter 21. There are some case studies at the end of the slide, and some questions. If you're interested in going back and doing those. Thanks. Have a good day.